How do you order TPN? How do you provide your patient with the nutritional supplementation that they're going to need to get ready for or recover from surgery, injury, or trauma? This is what we're going to talk about today. Welcome back to Citizen Surgeon, where we help you learn all the surgical knowledge that you're going to need to do well on the floor, in the ICU, in the operating room, and of course, to crush your exams. My name is Dr. Eric Pearson. I'm a pediatric surgeon, and today I'm totally pumped to talk about total parenteral nutrition. Just like every video, the first thing we're going to do is we're going to go back and talk about the review question from last time, where we talked about fluid and energy. This patient was a 53 kilo, 45-year-old female. She was a trauma victim on her bicycle, and she sustained a traumatic brain injury as well as a spinal fracture requiring fusion. She's now intubated post-trauma day 8 in the neurointensive care unit with pseudo-obstruction, moderate bilious nasogastric output. The questions were, what are her daily fluid needs based on weight? And how would you determine her energy needs? All right, so this is a really good question, or a couple of questions, because it makes you think about what are her maintenance fluid requirements, and also what are her energy needs. And like we talked about last time, when we think about total parenteral nutrition, it can be a really complex topic, but we can think about it in the beginning just thinking that it's a bag of fluid and energy. And so if we think about the fluid needs, we calculate her maintenance requirement or her daily fluid needs with the 4-2-1 rule. So that's 4 mils for the first 10, 2 mils per kilo for the next 10, and then 1 mil per kilo for the rest of her weight. So at 53, that's going to be 93 mils per hour. And then if you multiply that for 24 hours, it's going to be about 2,200 mils, 2,232 milliliters for the 24-hour period. Now you have to take into account her fluid losses and how much edema she has. So is she giving out a lot of urine? How much of that nasogastric output is out? And so is that really the volume that you want to give? But that's a good estimate. When we talk about her energy, this is a previously healthy 40-year-old person, right? And so they're going to be right in that 25 to 30 kilocal per kilogram per day range. And so if we use 25, which going back to the ESPEN guidelines, that would be a good estimation for her, then you'd be looking at about 1,325 kilocalories for her. And that would be her daily need. Maybe you'd need to increase the protein, maybe you'd need to increase the calories depending on what her indirect calorimetry would say, all right? We talked about that last time, and so if you need to review that video, definitely hit the card above. But this is a good place to start for both her fluid and energy. All right, so like every time we want to set our goals, there are 3 things that you're going to be super confident in knowing today. And that is, number 1, the indications for total parenteral nutrition. 2 is discussing the difference between peripheral parenteral nutrition and total parenteral nutrition. And 3 is talking about how we design a basic TPN solution. So we always like to ask why, and why with surgical nutrition, we've talked about it now in a couple of videos. It's critically important, not only when we look back at nutritional assessment and determining if your patient is a higher risk for infectious mortality and length of stay and other complications, but when we're designing a TPN solution, you need to know if and when your patient will need supplementary nutrition, have to choose between whether that will be enteral or parenteral. And when it's parenteral, you should have a really good idea of how that TPN solution is structured so that you can have an intelligent and educated conversation with your nutritionalist in the hospital, or if you have to write that yourself. There are a couple of really good references for today, and the first one I'd drive you to is the ESPEN guidelines, most recently published in 2017. And in this edition, they really go through a nice discussion of the ERAS approach and providing preoperative nutrition, as well as limiting fasting and that preoperative carbohydrate drink and how that affects your protein metabolism and your glucose levels. And in addition, it also goes through the nutritional assessment and everything you need to think about when you're providing nutrition for your surgical patient. So definitely check out this reference. I'll put it in the links below. The second one is one of my favorite papers when I talk to medical students, and this is by a couple of gastroenterologists. We mentioned it last time, and it's the Hitchhiker's Guide to TPN, and it makes it very, very clear, both the nutritional assessment and then how to design your TPN and start to think about the different solutions, the different concentrations, the different additives, basically everything you need to know to start thinking about how to put that TPN solution together, and we'll talk about that. So first, I'd like to just review what the ESPEN recommendations are on when is parenteral nutrition indicated. And so first, it's impaired GI function or unable to receive and absorb enteral feeding for 7 days. Also, in undernourished patients in whom enteral nutrition is not feasible or not tolerated, enteral feeding or a combination of enteral feeding with supplementary parenteral nutrition is your first choice. And so this last point is when you need to think about that combination. So if a patient's not able to take in 60% of their calories enterally, then you want to add in supplementary parenteral nutrition. All right, and so this gets to that whole nutritional assessment part, as well as determining what the patient's energy needs are. And this is a day-to-day thing. Every time you're rounding on your patient, you should be saying, okay, are they taking in enough calories? Not just enough food. You know, if they've taken in some more broth today and a couple of pieces of white bread, that's not going to cut it. So you really have to think about not the volume of enteral intake postoperatively, but the nutritional quality of that enteral intake, and are they taking enough calories orally, or do they need IV supplementation? Now, everybody likes lists, and so we're going to go over here to talk about a list of indications for TPN, and these are little clinical vignettes, but on exams, in oral discussions, roundsmanship, when you're asked about what are some indications for TPN, here are a few. So massive small bowel resection, you know, in my field in pediatrics, sometimes with neonates, whether it's necrotizing enterocolitis or malrotation or natresia, we end up having to resect a lot of bowel. Those children can get short-gut syndrome, then they're going to need TPN. Other indications, radiation enteritis, if you have high output enterocutaneous fistulas, I think if high output is greater than 500 cc's a day, and there are a list of others. So just have these kind of in your pocket to be thinking about those clinical vignettes where a patient would certainly need supplementary IV nutrition, and it's good for your boards. It's also good just to think about TPN. And so here we'll go through peripheral parenteral nutrition or total parenteral nutrition. Really, what's the difference? When we look at peripheral parenteral nutrition, this is going to be somebody that is typically a younger, healthier patient. They're going to need short-term supplementation for less than a couple of weeks. Their nutritional needs are less than 1,800 kilocalories per day. They have good peripheral access. There's a good rule of thumb, and that's if you've had to change the IV 2 to 3 times in the first couple of days of admission, those are not good candidates for peripheral parenteral nutrition. They don't have any fluid restriction issues. Usually with PPN, you're running this at a higher volume, so patients with cardiac, respiratory, renal failure are not good candidates for PPN. Also, these are lower osmolality solutions, so 600 to 900 milliosmoles. If you think about plasma, that's about 274 milliosmoles. TPN goes up to over 1,300 milliosmoles, and so these are less caustic to those peripheral veins that have lower blood flows. This is, like I said, limited use in patients with multiple comorbidities, can come in both fixed concentration commercial solutions, or you can customize it. And with these, intravenous fat emulsions are always piggybacked on, and they can be changed out every day. Now jumping over to TPN, so total parenteral nutrition, a little bit different, and so it's given via central access, and so these are the central veins. They have usually greater than 6 liters per minute of blood flow. the nutrition of choice in patients with fluid management issues. So think of that patient with congestive heart failure where you really need that minimal volume or that contracted volume total parenteral nutrition. Patients with poor peripheral access requiring greater than 10 to 14 days of nutrition. And of course, these are higher osmolarity solutions. And now let's get into each of the different energy components. And so like we talked about, we'll go through carbohydrates, proteins, and lipids. Now first, going through carbohydrates, we are carbohydrate burning machines, okay? So carbohydrates are the majority of the energy that you need to provide in your TPN solution. This works out to be about 60% of the total kilocalories that you need for the day. There are limits to this. There is a ceiling. And so the ceiling is 7.2 grams per kilo per day. And if you go higher than that, you risk hyperglycemia and all of its complications, but you also risk hepatic steatosis and liver damage. So that amount of dextrose that you can add has a ceiling of 7.2 grams per kilo per day. Popping over to lipids. So lipids come in as intravenous fat emulsions. Now you'll see this is that little bag of white fluid that's piggybacked on to either peripheral parenteral nutrition or total parenteral nutrition. And this is 20 to 30% of your total kilocalories per day requirement. The commercially available solutions, which would be intralipid or liposine, know that they contain vitamin K. Also, one thing to keep in mind with intravenous fat emulsions is there are different types of fats, all right? There are omega-3 fats and there are omega-6 fats. Now it's important to think about the difference between omega-3s and omega-6 because omega-3, that's your fish oils. Those are your immunosupportive fats. The omega-6, those are the ones that suppress the immune system. They're pro-inflammatory. And when we look back at the history of TPN, we know that the initial fats that we used were really pro-inflammatory. And even now, most of the content of intralipid or liposine is soybean oil, and that's omega-6. In some of the kids that I take care of, so little neonates with short gut syndrome, we use different fats. One would be SMOF, which is soybean, MCT, olive, and fish. And that's a combination of lots of omega-3, or OmegaVan, which is basically pure omega-3, and so it's much less inflammatory. And so think about that when you're thinking about the lipid component of your TPN. Too much omega-6 can be bad as it's really pro-inflammatory. Jumping over to proteins, we're going to start out with a protein requirement of 1.5 grams per kilo per day, and that's going to be a good start. Now you want to think about those patients like, for instance, burn patients or patients that have like a nephrotic syndrome with renal failure and they're giving up a lot of protein. They might need more protein. Other patients, maybe a uremic patient, might need less protein. So you want to think about how much protein you're giving, but 1.5 grams per kilo per day is a great place to start. So branched chain amino acids are an important source of fuel in injury, and they provide a source of glutamine and alanine for ongoing recovery. And of course, you know, like we talked about in the metabolic response to injury, go ahead, check that video out. The protein that we give in TPN, the calories that we give, are to suppress more muscle breakdown, to suppress more protein loss. We don't actually get to rebuilding until we get to that recovery phase that's after that ebb and flow of that pro-inflammatory phase. So think of the protein that we're giving, not so much to build a patient back up, but to limit whole body protein loss. And so here we'll go through a sample calculation of somebody for a basic design of TPN. And so let's say we have a previously healthy 70-kilo male, had a gunshot wound to the abdomen, he's left in discontinuity, and he needs TPN. It's been a week. Let's say it's only been a few days, but you know that this patient is going to need supplementary nutrition. So first, let's talk about his fluid. Now we can easily go through and talk about what we think his fluid needs are going to be with the 4-2-1 rule. And so if we do this, we're going to come up with 110 mils an hour or 2,440 mils for the day. Now also you have to take into account NG output, fluid output, his edema, how is he doing on the event, how much output is coming from his wound vac. that'll give you an idea, but this is a good starting place. Then we can jump over to energy. Now first, we're gonna know that he's gonna need about 30 kilocalories per kilogram per day. 25 to 30 would be our range, previously healthy guy. But let's say he's got a big injury here, he's an open abdomen, I'm gonna wanna start at the higher end of that. So I'll give 30 kilocalories per kilogram per day, 2,100 kilocalories. When we start with our lipids first, so that's 30% of our daily need. That comes out to about 630 kilocalories of lipid. Now, if we use a 10% solution, now remember, that's gonna be 10 grams per every 100 milliliters, or 100 grams in a liter bag. That works out to 1.1 kilocalories per milliliter. And so we're gonna need 572 mils of a 10% intralipid solution. Now, look at these percentages and think why that percentage is important. The nice thing about it is it gives us a range. So maybe in that fluid restricted patient, we would want to use a 20% solution or even a 30% solution. So that's why we have those different concentrations. Jumping down to protein, 1.5 grams per kilo per day, that's 105 grams of protein. Let's use an 8.5 aminosin solution. So that's gonna be 8.5 grams per 100 or 85 grams of protein per liter. And so we're gonna need 1,235 mils of that solution. Then it comes down to our carbohydrates. So how do we calculate our carbohydrates? Now, carbohydrates, the best way I've found to do it is subtract the lipid and protein volume from the total volume, subtract the lipid and protein calories from the total calories. And so if we do that, we're gonna get a need of 633 mils of fluid, a need of 1,050 kilocalories of energy. And so remember dextrose, that's 3.4 kilocalories per gram. You know, going back, protein is 4 kilocalories per gram, lipid is 9 kilocalories per gram. And so if we know this, we can divide the total calories divided by 3.4. That's going to give us our grams of dextrose, little stoichiometry here. Divide that by the total volume, and that means we're going to have a 12.6 solution of dextrose. And as you can see, when we think about, oh, well, is this even close to our ceiling, 7.2 grams per kilo, 70 kilo man, so that would be, you know, about 490 grams of dextrose would be our ceiling. So we're well below that, not going to be a big risk for hyperglycemia or hepatic steatosis in this patient. All right, so how about electrolytes? Now, it's important to know the highs and the lows of each of your electrolytes. So sodium, potassium, bicarbonate, magnesium, phosphorus, calcium. Got to know all those. We'll go through them in the next video on fluid and electrolytes, but here I just want to give you, these are some starting additives to what you're going to need or what your patient's going to need for electrolytes every day. And again, we're going to go that in detail in the next video, but here's a good starting range. I'm not going to go through this, but this is the ESPEN Recommendations, and you can see here for all the major electrolytes, this is what you would add into your TPN solution. Now, what are some other additives? So we can start out with lipids. Now, remember, we talked about we want a greater concentration of those omega-3 polyunsaturated fatty acids that are anti-inflammatory. With the amino acids, there is some evidence that shows that additional glutamine and arginine supplementation can improve outcomes. With our nutrients, even if they're healthy or unhealthy, we're going to want to add in, you know, vitamins and essential minerals every day. So micronutrients and antioxidants should be supplemented in TPN daily. Coming over to insulin, consider adding 1 to 2 units per 10 grams of carbohydrate for patients with persistent glucose levels over 200. So in our patient, we were using 309, and so you would want to use about, you know, 30 units of insulin in that patient to start, and that would give you a good glucose control if indeed your glucose levels were over 200 a day. And then sometimes we end up adding H2 antagonists to our TPN solution to prevent GI ulceration. And I would add in, I don't have a bubble for this, but you know, sometimes we also do supplement iron in patients who need that extra mineral. So one of the things we talk about is, do we need individualized solutions? Why can't we just use custom commercial solutions? There are a few patients in particular that really benefit from individualized custom solutions. So those are your chronic renal failure, heart failure, respiratory failure patient, where you really need to think about that fluid volume. So sometimes in that ordering that TPN sheet, you're going to see a little checkbox for minimal volume TPN. That's what this means. So you want to fully concentrate it so you can give the minimal amount of volume, because you don't want that patient with congestive heart failure going into more heart failure because you've bombed them with fluid in the TPN solution. So second is, in patients with chronic renal failure, sometimes they need to alter their protein levels depending on what type of renal failure they have, whether they're holding on to protein, they're uremic, or whether they're losing a lot of protein. So that comes into account. And another patient that needs an individualized solution. Third is liver failure patients. We used to protein restrict these, but that's found no longer to be needed, so you don't need to do protein restriction on liver failure patients. And then finally, patients with high output intercutaneous fistulas can have dramatic fluid shifts, and those patients should probably be on individualized solutions as well. So these are those patients. Think about them. These are good reasons why you need to be able to do custom total parenteral nutrition. Now, what TPN talk would be complete without talking about all the nutrients and the deficiencies? So maybe you want to screenshot this one in the next slide, but each of these vitamins has an associated deficiency, and this is like testing gold. Every test you take in medicine is going to at least have one question on this, and usually a couple. So the important ones are your thiamine deficiency, folate deficiency, niacin deficiency, your vitamin B12 deficiency, then of course all the fat soluble vitamin deficiencies. And then on the minerals, there are some of these that are super rare, but go ahead and screenshot this and you'll have kind of a good collection of all of the major mineral deficiencies and how they present. Another discussion to have is, what's better, a 3-in-1 solution or a 2-in-1 solution? Well, a 3-in-1 solution is certainly more convenient. You have to change it every day because the lipid component needs to be changed every 24 hours to prevent contamination. But this is just a very convenient way to give the nutrition. Now, there are some medications that are not compatible with TPN, so you'd have to have another line if you were given a 3-in-1 solution. A 2-in-1 solution you might see in the neonatal intensive care unit. And so this is where you have that the lipids are separate from the protein and the carbohydrates. They are piggybacked on. The lipids are changed every 24 hours. And this is just another way that you can provide total parenteral nutrition. So how about weaning? So traditionally, TPN has been tapered for discontinuation to prevent hypoglycemia. But what we found, and in the ESPEN guidelines, you can read that glucose levels return to pre-infusion baseline without hypoglycemia, and this occurs within like an hour. So typically weaning is not needed, and when you're no longer needing TPN, you can go ahead and discontinue it. So let's summarize up. For TPN indications and design, we've learned that peripheral parenteral nutrition can be adequate in healthy patients with good IV access and short-term needs. We learned to break down those energy components into 60% carbohydrates, 30% lipid, and 1.5 grams per kilo of protein. We talked about the different additives for TPN, that vitamins, micronutrients should be added daily, and that TPN should be individualized in particular patients. And we talked about the different patients with morbidities such as congestive heart failure versus that patient with a high output intercutaneous fistula. So I hope you enjoyed that talk today. I hope you're confident in knowing the indications for TPN, the difference between peripheral parenteral nutrition and total parenteral nutrition, and of course, how to put together a basic TPN solution. Now, next time we're going to talk about fluid and electrolytes. We'll talk about the fluid needs and the electrolyte needs of our patients, as well as the different electrolyte deficiencies and excesses, like hyponatremia, hyperkalemia, hypocalcemia. How do those present? And what are the levels that we should be thinking about? So that's going to be next time. So let's go ahead, let's talk about our clinical vignette, and then we'll tie everything up. So today we have a 25-year-old, 85-kilo male admitted to the surgical ICU with an open abdomen after damage control surgery and MVA. He sustained solid organ injury, avulsed multiple segments of his small bowel mesentery. Now he's in discontinuity. Write up a basic TPN solution for this patient, and what are some of the major considerations of his ongoing TPN needs. All right, so next time we'll go ahead and we'll talk about that. And if you haven't had a chance to subscribe, go ahead, hit the subscribe button. If you haven't had a chance to turn on your notifications, turn on some notifications, and you'll be the first to know when a new video comes out. If you have any comments, definitely engage. I will answer all the questions that you have. If there's a topic that you want to learn about or that's kind of the top of your list, go ahead, throw that down in the comments. We'll put a video on it. And also check out citizensurgeon.com. I have a lot of good resources on there. There's a blog, and I talk about different things like mentorship, how to match as an international medical graduate, how to find balance, what are some of the things we can think about with burnout, and of course, some of the textbooks I'd recommend. But we can go through that in future videos as well, but definitely check that out. All right, I will see you next time.